It is my pleasure to introduce to you Andreas Heri, a promising anesthesiologist resident who will be sharing insights on the fundamentals of ultrasound targeted puncture with us today. As we delve into this essential topic, we have the opportunity to learn from his expertise, and then afterwards in the hands-on session, there will be the workshop where you can try those techniques. Please join me in welcome Andreas Heri.
All right. Thank you, Sono, for inviting me. And thank you that I have this opportunity to talk a little bit about ultrasound-targeted punctures, because I feel like they're very important, and not just for anesthesiologists, for doctors overall. And they're very easily taught. You don't need a lot of training. Usually it's quick and easy, and it helps you in clinical practice enormously. And as the amount of ultrasound devices rise, you will need it much more often, and you can use it so frequently. Because back in the day, you used to have a couple of ultrasound machines around, and the wards didn't have any, and maybe the ICU had one, and the OR had one altogether for a couple of ORs. And it wasn't until, I think, recently that even for us at LKH, we were limited with ultrasound devices. So in the morning, we had to wait for the device to be available. And all those things are going to change. And I think it's for the better, because ultrasound-targeted punctures can facilitate your everyday work a lot. Just a short thing about me. I'm a resident at the Department of Anesthesia right here in LKH. And I use the ultrasound machine every day, and I didn't get any special degree or training for ultrasound-guided punctures. So when you start working and you feel like you didn't get a lot of training during your studies with the ultrasound machine, don't worry, just work with it, do something with it, and an approach to get used to ultrasound would be targeted punctures, because you gotta do a lot of punctures if it's a venous line anyways, so you might as well do it with the ultrasound aiding you. And in this way, you will learn how to use the ultrasound even more for other things like abdominal, or if you want to do an echocardiogram. All right. I'm going to talk about a few topics that are the most important for my everyday work. One will be central venous lines, which you can put in using the ultrasound, arterial catheters, and the big topic of regional anesthesia, which is a little bit more specific and more for anesthesiologists. But all the other punctures are used and will be used in all fields of medicine. So, before any ultrasound-guided puncture, I would suggest a few steps before you start looking at the patient, start looking at the ultrasound machine, because it's so much easier if your setup is correct. And if you spend more time in preparation, you spend less time during puncture and catheter placement. And it just facilitates everything so much. So think about patient positioning first. Most ultrasound-targeted punctures only take a couple of seconds, minutes, but if it gets harder and you can't find anything and everything looks the same because it's all black and gray and there are no colors, you want to be comfortable. So you want to have the table at the right height. You want to have the bed at the right height. If you're in the OR, on an intensive care unit, or just on a normal ward. Make sure your access toward the body is easy and that you can stand comfortable. If I stand like this and I lose energy, I might not be able to perform ultrasound as well as I would if I were to stand comfortably from the beginning. And then think about the positioning, not just your positioning, and also the positioning of the patient. Does the patient need to be in a supine position? Does he need to be in a Trendelenburg position because maybe you need to have the blood go down towards the head or down towards the leg? Do you want him to be with his upper body upright? Do you want him to be like in a beach chair position? And you got to think about those things at first. So patient positioning, and the next step will be to have a raw understanding of anatomy. Now, you don't have to be an expert on and know every muscle and every structure that you see in the ultrasound. It's not necessary at all. But you got to get some landmarks correctly. And the way to do it is before any puncture, I would always suggest getting an orientation without looking through the ultrasound. Look at the muscle, look at the body from the outside. Where is a bone? Where is a muscle? Can I see it? Is it an obese person? I can't see anything. At what angle does the extremity lay? Is it rotated in a weird way? Can I even produce the ultrasound imaging I want if the extremity is rotated inward or outward? You can see veins running through the skin, like the external jugular vein, and you can see, we're going to do some ultrasound of the neck later, and you can see a big muscle, which is huge in horses, the sternocleidomastoideus, and it helps you find things on the ultrasound even easier. So first of all, check your anatomy, and then go into ultrasound imaging. And always think about being well prepared, because a lot of punctures, different than just examining a part of the body where nothing has to be sterile. Punctures need to have a sterile environment, sterile conditions. And especially for central venous lines, you want to ensure sterile conditions. And if you move away from your table, from the patient, and if you have to adjust the ultrasound probe, let's say the transducer cannot show everything, I didn't cover the right parts of the body, those are all problems that can be prevented beforehand. So that's, like, always think about this. More time in preparation means less time overall. And time is always a big factor. And it's so annoying, but it's the way it is. You know, you have a limited amount of time, you have several patients, or the OR needs to get going, the surgeon wants to perform his procedure, or you have to be somewhere else right now. Or it's late at night, and or it's an emergency and you have to be fast. Good. So, any kind of puncture that you do with an ultrasound machine, there are basically just two options. You can either be in plane or out of plane. In plane meaning that the cross-section imaging that you show is this parallel to the way you move your needle through the tissue. So the pathway of the needle is parallel to the ultrasound cross-section imaging. That way you will always see the entire needle. You will see the pathway of the needle, the angle of the needle with which it goes through the tissue, and you will see the tip of the needle at all times, ideally, unless you have a skewed image because you're not parallel with the transducer. So for in-plane approaches, you need a good hand-eye coordination, and you always have to think about it. There's so much that can go wrong axis-wise, because it happens very quickly that I'm not parallel anymore. And if I'm not parallel with my needle and my probe, I use the whole imaging of the needle, and we will see later, maybe we can use this model and we can show how images get skewed. So that will be the in-plane approach, and then there's the out-of-plane approach. If you use the out-of-plane approach, you will only see one section of the needle, whatever section that goes through your imaging. So you move into the 2D imaging with the needle. Now the advantage is that lateral movement of the needle can be very well controlled, because you see it in the cross-section imaging very well. However, you have to ensure that you only see or try to only see the pinpoint of the needle. Because if you don't see the tip of the needle might be somewhere else, and you're just imaging one part in the needle, and the needle might be 2 centimeters further down in the tissue and deeper down in the tissue, depending on the angle in which you inject. And I will later show you like a little video on how to best perform it. 2 pictures, the one on the left, in-plane approach. In this case, it's regional anesthesia and regional anesthesia needle. And the approach on the right would be an out-of-plane approach for a vascular access. In this case, it will be a central venous catheter. Advantages and disadvantages of different approaches. If you think about doing an ultrasound of the neck, you know you have limited space, and as people get more obese, you even have less neck, and it's hard to show everything and find anything and move a needle within this small space. Now, if I turn the ultrasound probe and I have an in-plane approach, you can imagine like it just takes up a lot of space, because your hand needs to be here, your needle needs to be here, and that's where the probe is. So you need all this space just to perform it. Whereas the out-of-plane approach, you only need this amount of space. If I'm limited in space here and here, it's a whole different story. So, another advantage of the out-of-plane approach, I would say, would be vessel identification. If you have a cross-section of a vessel, if it's an artery, and it's a small artery, it's very easy to find it if I do not cut it longitudinal-wise, but laterally. And if the vessel is perpendicular to my probe, I can find it very easily, even if it's small. But if I use the in-plane approach to puncture a vessel, I would have to be very exact with my probe to be just above the vessel, and also to not be skewed in the angle. Disadvantages would be always knowing where the pinpoint is, because that happens all the time. And I would never be so bold as to say that I always have just the needle pinpoint, the tip of the needle in my imaging. It will be further down many times. So puncture depth is harder to identify, and I don't know the needle pathway because I just have one cross-section at one point in the needle. Should be the pinpoint, but I don't know what happens before. I don't know if the needle hit an artery, went through the artery, back out the artery again, and then went into the vein that I want to puncture, for example. So that's why both approaches are used. And here I have the video. Let's hope it starts. So that would be an out-of-plane approach. So the probe is perpendicular to the needle, and the video shows like exactly how you want to perform it, ideally. You want to move the probe away as the needle enters deeper into the tissue, so you always see the pinpoint of the needle. But I can assure you, it's not always going to be like that, because you're going to like push in with the needle, and then and then you're far too deep in, and the needle and the pinpoint of the needle is already like over here, or you're far too steep, and then you have to go back and correct. If you don't think about correcting and you just hit the needle, and you will always see a certain cross-section of the needle, let's say here, you have no idea where you are. And let's say you want to puncture a vessel and you want to do an aspiration, and to ensure that you're in the vessel, your needle is somewhere down there. There's no aspiration here because you've maybe hit the artery or the vein. You might not have. You might have hit another one, but you sure as hell aren't where you thought you would be. So always think about it, especially when structures are not as deep in the tissue. Probably the most used or most common vessel approach that is ultrasound guided would be put in a central venous line, central venous catheter in the internal jugular vein. So that's what's happening here. Where do you think the head would be? Because it's all covered. Would you think the head is under here, or is it under here, or here? If you think about anatomy, the head should be up here. Because where should the central venous catheter go? Towards the heart, right? So my puncture, with which I will use the Seldinger technique, will move towards the heart, and the head will be up here. And as I said, in the neck you have limited space. You want to puncture a vessel, so what approach are you going to use? Most probably the out-of-plane approach. I stole that video, it's not mine, because if I were to make such a mess, like, my colleagues would be very mad at me. And already I'm startled, because a big complication that arises during this procedure almost just happened. I don't know if you saw it. So, you're doing cross-section of the neck. So you have two vessels here. What vessel is this? If you want to hit the internal jugular vein, carotid artery. And this should be the internal jugular vein. So you see it's big. It seems super easy to hit. So what's the big fuss about ultrasound guided punctures? And why do we even have to talk about dangers of it? But it happens even in this video. He puts the needle on the tissue and he punctures, but the carotid artery and the internal jugular vein, they're so superficial that just by going through the skin, he almost punctures the carotid artery. With an 18 gauge needle, it's a big hole. It shouldn't be any problem usually if there's not a severe amount of anticoagulation happening. But if I dilate the carotid artery, I have to call a vascular surgeon. And it happened so quickly because he was just a little bit towards the medial part of the neck. But he manages to go to the right and hits the internal jugular vein. And as he hits the vein with the tip of the needle, ideally he should aspirate blood, right? So to aspirate the blood, it's just to control that you have the right positioning. There's no special reason to aspirate blood. Now I want to talk a lot about this approach and this procedure because I feel like it's the most famous or most common one, most important one for ultrasound guided punctures. You have a question?
Did you watch the video?
Yeah. Try. I don't know. I think if I move, should start now. Okay. Look at where he punctures. Oof! That seems close. And you see, like the tip of the needle, it's already in the vein. He just he barely punctures the skin, but the skin has a lot of resistance, so you fall into the tissue, and after the skin it's more soft. You don't have big fascia that stop you from hitting the carotid artery, like it is in lower parts of the body, where there's like a big fascia that you still have to puncture. You fall into those vessels. And I want to tell you the story of the first time I did this and what happened to me. because I didn't show the pinpoint of the needle in my ultrasound. Like I hit it and I thought like, oh, I'm so good at ultrasound. I have like, it's just in the middle of my cross section. It's just, it goes directly towards the internal jugular vein. The carotid is far to the left, perfect. And I tried to aspirate and I don't get any blood. And I'm just looking at the imaging. And that's where my mistake was. Whenever something doesn't seem right, you go back to anatomy first. You look at the patient. Is the needle maybe too far in? Is it in at all? Did I slip out? Anything can happen if I just focus on the screen, which happens because you're trying to maneuver two things at the same time. You have to have the coordination and you want to look at the imaging. And what happened to me is like I tried to aspirate and I went deeper and I aspirated more. And then I hit some resistance and I was like, wow, I think I hit like a bone. And that's not a joke. It was a slim patient. And what do you think I hit? The clavicular? No, I thought that too. You know what? I thought I hit the what's that bone called? I didn't. You know what I hit? I hit a vertebral. So you might think ultrasound guided punctures are always so safe because I can see everything, I won't hurt anybody, but statistically speaking, they're not more safe at all. The same complications can happen with ultrasound guided punctures, just as they do if I only do landmark oriented. So always think about it. Okay, let's watch the video again. I don't know how I got it to go. Would you see another mistake he might do? I would always put like my targeted structure as a landmark in the middle of my cross section. So I always want to look at my targeted structure. I want to have a landmark that gives me orientation at all times if I can't find anything else, also in the imaging. So the artery is always a good tip for something like this, because the artery, like it pulsates and you can use a Doppler and everything, and you can identify it very easily in all parts of the body. So it should be shown in the screen, at least in the beginning, but actually he wants to hit this vein. So why not move the whole cross section to the left? He's less likely to hit the artery and more likely to hit the internal jugular vein. So if you think about the mistake I did when I did it the first time, and that's what you always should do with punctures that are out of plane, move the needle back. Move it back, and if it leaves the screen, if you don't see it in the screen anymore, the pinpoint is behind the transducer, and then you go in again. Don't aspirate too strongly because those veins can collapse easily. Put the transducer on with just a minimal amount of pressure. Put the patient in Trendelenburg, and you get a lot of blood fill to the vein. And that's how you most easily perform this procedure. If the patient is severely hypovolemic, sometimes even like the slightest pressure of your ultrasound probe might be too much and you can't even perform it. Because if you aspirate too much, you're just going to suck in the side of the lumen and not the blood. And you're just going to collapse the vein. All right. Now, if I do a vascular approach and I want to do a catheter, I want to put the needle in the direction that the vessel goes so the catheter can go in the best way. Now with the Sellinger technique, you have a wire that you push into the artery and into the vein. And where is it going to go? If I push it in all the way, into the right atrium or right ventricle if I move. Yeah, for sure. So always look out for arrhythmias. You can look out for arrhythmias as proof that you hit the right pathway, but Yeah, but we did have to do CPR after central venous line placement just by irritation of the wire. So that's a real problem. And if that happens, move the wire back and hope for the best, or get the machine. So now I have a wire in. I did aspirate blood. So I can use the ultrasound again to prove that I'm really and surely in the right vessel. So I put the transducer on, and I should see the wire, which I do, the wire reflection. And now I have a question for you. You do the whole thing just as he does it. Everything works great, and you don't see one wire, you see two wires. What happened? It does a loop and moves back up. And if I put in the central venous catheter, that can do the loop as well, and the positioning is bad, and maybe it goes back up and doesn't even go back up towards the internal jugular vein. It can go anywhere. So the ultrasound right here already has a big advantage. I can prove my positioning of the wire not only by arrhythmias, but I can also see if I see it twice, it did a loop. Okay, he only sees one. It went in grades, so he can continue with putting in the central venous line. All right. Regional anesthesia, local anesthesia. Some people just say plexus or blocks. Always make sure when you're naming it, if you're blocking a plexus, it needs to be a plexus. You cannot say I'm doing plexus anesthesia and you're actually blocking a peripheral nerve. Yeah?
When you have the twist in the central line,
Yeah.
if you are not doing the puncture with ultrasound because it's not available, you have to do it fast.
Yeah.
Is there some way, like, though that it's twisted, like you can aspirate or you can flush it?
Imagine this. If it does a twist, you put in the central venous line, you're still in the internal jugular vein, you aspirate, you still get blood.
Yeah.
So that can be a proof, right? Yeah? You do an X-ray. You can only do an X-ray. You have to wait for an X-ray, yeah. But if I can aspirate venous blood easily, and time is of an issue and I cannot do an X-ray right away, I would accept it. Because I don't know. I would think it's in the right position. Might not be. But if it did a twist and it's still in the internal jugular vein, I can still use it actually. But just for a certain period of time, because it might hurt the vein or it might fold and not work anymore. So you actually can only do an X-ray. And you also have to do an X-ray when you do it ultrasound guided, because you cannot always be sure that it didn't twist anyways, or it twisted later, or it's too deep, or too, yeah. Nah, honestly, like, if I move the wire and I have arrhythmia, I'm pretty sure I'm in the right position. Honestly, and if I don't get any, I do like this. And I shake up the heart. Yeah, it's because for if I do infraclavicle approach, I never use the ultrasound because it's much more easier and it's quicker sometimes if you do landmark oriented. So in an emergency setting, I don't always use the ultrasound, even though it's very practical. And there, I trust those things. Yeah. All right. So plexus anesthesia blocks. We use it basically for perioperative pain management, and we can do some surgeries just by doing regional anesthesia. If you have extremity surgery, it's very practical because there's just one nerve that goes down the line, and usually at the end of your fingers and toes, there are only a few more nerves that you have to block in order to produce a total block of pain, and you can perform surgery. You can do ankle surgery. You can do open reduction, internal fixation of the radius by just doing regional anesthesia. So for extremity surgery, it's very practical because you can do it just in regional anesthesia. But if it's not possible to do it just in regional anesthesia because you cannot block all the nerves that intervene the part of the body that's being operated on, it's still good because of perioperative pain management. Because if I do anesthesia, the pain is still there. Like, it still fires, you know? I just do anesthesia so the patient doesn't feel the pain and doesn't remember the pain. But it's still taking place. So blocking nerves is a big part of my job. Might even be part of other fields of medicine. And here are my personal thoughts on approaches for regional anesthesia. If your goal is to get a certain amount of local anesthetic to a certain region of the body, and I just want to do a single shot, so I just want to have it around the nerve for the surgery until it's being resorbed, and I want to make sure that it goes to this area exactly, I would do an in-plane approach. But if I hit the cross-section perpendicular to a nerve, and I want to put a catheter for, let's say, a patient-controlled regional anesthetic that can flow continuously or intermittently, I will want my needle pathway to go the same way as the nerve, because this way I can ensure that it goes alongside the nerve, just right next to it, and can block the nerve in the best way. You can do in-plane approaches, go perpendicular, hit the nerve, and put a catheter in this way, but it has to go in the right way, and it shouldn't twist and go back again. So that's my thought on approaches. I would always think about where I want to put the catheter, and does it make sense, and is it easy to put it in the direction that I want it. Now, online or most regional anesthesia approaches are in-plane. It's more commonly used because you always see the whole needle and the whole pathway. But I still do a lot of out-of-plane approaches, especially when the structure that I want to block is very superficial. Because if the problem that we had for central venous lines, incorrectly hitting an artery that I don't want to hit because it's so superficial, is actually an advantage if I want to do a block, because I hit the needle and I'm just where I want to be, because the nerve is so superficial. I don't have to go all the way from the lateral part of the transducer, go through muscles where my needle gets stuck, or I go through a fascia, and I do more trauma than I have to. Probably not everybody sees it in the same way, but that's just my thoughts to it all. So regional anesthesia, that's like my setup from my last night shift. So I didn't even, you can't see anything, I'm sorry, but it was already sterile, and I wanted to take a photo and I couldn't move it anymore because I just threw it on. So I have the ultrasound cover, of course, because it should be sterile. There's the needle, and you can see the needle has a little wire connected to it. And I don't know if any of you know what the wire is for, but the wire is for nerve stimulation. You put on an electrical current on the nerve, and if the nerve is a motor nerve, you can see the targeted muscle group move, and that way you know that you're close to the nerve. And that's the way you did regional anesthesia before you had ultrasound. And those needles still have the wire, and I'll talk about it a little bit later. And then something to clean. So I use the good ultrasound machine, which I love, because it shows you the tissue so much better. The reality is sometimes you have older machines, and then they don't have such a good resolution, and it can make things very hard sometimes to locate nerves, because different than vessels, I think nerves are hard to see. especially because traumatic injuries cause hemorrhage and blood in the soft tissue, and it all looks the same sometimes, and it's really hard to see the nerve. But there are a couple of tricks to understand what is the nerve, and again, here it helps to have the raw understanding of anatomy. So I got this video for the big screen again later. I already did my injection. You see, like, there's a lot of black around the nerve. Would you be able to guess which kind of nerve it is? I wouldn't be, but just by looking at the picture. But it's, if I say Ivan, do you know which it is? It should be the femoral nerve. And it is. So that's the whole game. You move the probe and the needle, and you want to be parallel. And you can either move one or the other or both at the same time. But in the beginning, I would always just try to set the probe at the correct position and then just move the needle, because then you have to only think about one thing at a time. So I just blocked the nerve. This is my very sterile setup. As you can see, I have this little cover here that I always, You do your best to be sterile. And if you have a well-prepared anatomical situation, you don't have to put immense amount of covers to perform it in an almost sterile way. So the image that you just saw is basically this one. I have the femoral artery. The most inner part of the thigh should be, if you think about Ivan, should be, I always say, internally, or the medial part is the vein, then comes the artery, and then the nerve. So locate the artery, and next to it should be the femoral nerve. Sometimes it can be hard to find, and to find it easier, think about it. It lays just above the iliopsoas muscle in most cases, and just below the fascia iliaca. But sometimes it's here, and sometimes it's here, sometimes it's here, and sometimes it's here. If the leg is weirdly rotated, which can occur in surgeries like this, because why do you think I'm performing a femoral nerve block? Because it was a femur fracture of an old lady, and she got a paratrochanteric fracture and got a medullary nail. And this blocks a lot of the pain during surgery, and you don't need as much opioids after the surgery. So the rotation of the leg defines which way the nerve goes. And sometimes it's not right next to the artery. But to find it, my landmark should be the artery, as it is for most regional anesthesia and for most blocks. And that's the video before injection. So I guess you guys can see. And that's the good ultrasound. And I don't think it's so easily to understand all the structures and all the fascia, which is which. Because if we go back again, it said fascia iliaca, and I don't see any other fascia here shown. So where the hell is all this fascia coming from? And where is the muscle? And where is my artery? Okay, we found the artery, right? Because it moves, and it's an older lady, so she has a little plaque here in the artery. Little, it's pretty big. But next to the artery is the femoral nerve. But if you look back at the image before, it seemed to be much closer to the artery, and it isn't. But it looks kind of the same, right? It has the same form. It's like this oval shape. And here's my needle. Now, would you say I do it like super good and correctly? Or do you see any like mistakes I would make? Right now it was pretty good because I just hit the pinpoint of the needle. Like you see this? This is the pinpoint. But as soon as my imaging gets skewed a little bit, I only see a section of the needle, and you can always see sections of skewed lines. If it's a needle, an artery, or whatever, if it moves as I move the transducer up and down, the needle seems to move while I'm not even moving it, because the reflection of the needle is at some point in the upper part of the needle and then in the lower part. So the reflection changes, and that's how I know that I haven't shown the needle ideally and that I'm not 100% parallel. And that's what happens here. Like reflections here, then it goes up, then it goes back down, and now I have a good image because I have the whole needle on it, kind of. Okay? So I infiltrate local anesthetic just below the nerve, and I don't try to hit it with the needle because you don't want to get nerve damage. And as I inject local anesthetic, it will lift up from the muscle, and it will show its true nature and color and be more well visible, and you will see it with the next regional anesthesia even better. So I did that, and then I injected the local anesthetic, and I want to do another block, a block of the cutaneous femoris lateralis, which is very good to block because if you cut on the side of the thigh, it blocks a lot of the pain of the surgical incision. So the femoris lateralis will be to the lateral part of the thigh. So I move my probe towards the lateral part. And now I don't have an artery anymore to show me where I am. And everything gets more difficult because now it's only soft tissue, muscle, and it's so much harder to find anything. So always think about that. But I can always go back, find my artery, and I know if I leave the artery and I leave the femoral nerve, there should be a muscle in between the cutaneous femoris lateralis and this image, and it's the sartorius muscle. And you can see it very well in this patient, this one. And it really looks like a nice muscle. And then you have laterally of this muscle, I know because anatomically it has to be this way, the tensor fasciae latae. And in between those two guys, just above the fascia, should be the nerve. Now the nerve is very small and sometimes hard to see, especially in thinner patients. For bigger patients, obese patients, it's in some adipose tissue, and you can differentiate it better from the rest of the tissue, which really worked well for this patient because she was a little bit bigger. Now, you see the needle, in this case, I did it right, okay? That's how it should look if the needle is all the way in your cross-section view. And as I inject local anesthetic, I can see the nerve even more clearly. And always think about that. Try injecting some glucose and not local anesthetic right away, because as I inject fluids, I can see the nerve better. Right here, I cannot see it. And now it shows, oh, and isn't it nice? It's so white. And I'm annoying it with the needle, and I always try to twist it because it's if I go to the peripheral part of the nerve and I can twist it and it turns, and this way I can be sure it's not a muscle fiber. Okay, so I blocked two nerves, and we can start with the surgery. And it was only possible to do it that quickly because I did a decent preparation. I looked for my landmark and so on. Now we talked about nerve stimulators, this regional anesthetic needle with a nerve stimulator. Now you might say, you can see the nerve, we did it all without stimulation. Why would you even need this anymore? This is obsolete, ultrasound is the best. But if we have two eyes, and if you have two eyes, why only use one? You would have another way to making sure your positioning is good. And that's why I also still use nerve stimulator, even if I see the picture very clearly. Because if my needle pinpoint isn't exactly where it should be, or the needle is just below a fascia, sometimes I cannot stimulate the motor nerve. And regional anesthesia is just below the fascia. It doesn't go to the nerve isn't blocked, the patient feels pain. And if it's a type of surgery where I rely on regional anesthesia working for it to even take place, I have to put him under general anesthesia just because I didn't plug in a nerve stimulator because I thought I'm so cool I can always do it without one. So why, if you have it, why not use it as well? And you have another check to be in the right positioning. And sometimes it's hard to see anything. And you run into limitations all the time during regional anesthesia. And that's how I get to like the annoying reality. I didn't do my preparation right. Am I working in sterile conditions? Am I doing a single shot regional anesthesia where it doesn't matter? Or am I putting in a central venous catheter that if it gets infected, and it might not have been 100% necessary to put it in anyways, I might cause an infection to the patient that didn't have to take place. So it's 100% my fault. Obese patients, they have a lot of adipose tissue. The access is harder. You need bigger needles to even find or even reach the nerve. Did I use too much gel or did I use not enough gel? Because if I don't use enough gel, I cannot move the probe around a lot. And once I start the thing with the needle, I cannot like go back, put some more gel on. But then if I use too much gel, I don't know, I puncture a lot or I put in a catheter and I have to move and it seems dirty. And then all the gel is on my hand and the probe slips out of my hand and I can't hold the needle. It's annoying. Sometimes it all looks the same. And whenever that is, go back to step 1, patient positioning, then check your anatomical landmarks, and then go into imaging, find your ultrasound landmark, which usually is an artery, and find the nerve. And always think about, does my ultrasound even facilitate things right now? Or am I just making things harder? Does it take more time than if I just did it without an ultrasound? Do I need to do regional anesthesia? Does it have to be this way? Or am I even if I use the ultrasound and I hit the artery while aspiration 3 times, maybe I have to think about changing the positioning. Am I even having an advantage right now? Positive aspects of the ultrasound guided punctures. It doesn't need a lot of practice. It doesn't need a lot of expertise. It's not like an echo. You don't need to learn a lot of techniques. You can just take one and try to puncture a vein. Next time you're on the ward and it's a patient that has difficult veins to puncture. Usually any ultrasound device will do because you mostly use linear transducer because most punctures are superficial because needles aren't that long and you don't need a sector array. Usually it's quick and I think it's fun. It's fun to practice and it's like playing a video game at times. And maybe we can do a quick ultrasound of a neck. Yeah. Oh yeah. Yeah. Perfect. So we're a little ahead of time, but we can do it in small groups, and you can do an ultrasound of the neck, and you can see how what I just told you applies. All right. Thank you all for your attention.
Perfect. Thank you so much.